Hi, everyone. Welcome to our video salon, where we're excited to discuss perimenopause and menopause, your changing hormones and the effects on your brain and mental health. All of our attendees today are muted, but you can still submit questions through the Q&A feature in Zoom. You'll see it down at the bottom of your screen, right there, Q&A. And if you click on that, you can ask questions at any time. And we'll be taking questions sort of towards the latter half of this Zoom and of the hour. We will be combining questions that seems a bit similar. And also, please try to keep your questions more general and not specific to any of your individual symptoms and experiences. If you want your questions to be anonymous, you can click the anonymous box. We will be working to reply to all questions throughout this Zoom. So before I introduce Taylor Sittler, the CEO and co-founder of the Cusp, and Dr. Louann Brizendine, Neuropsychiatrist, we're going to give you a small disclaimer, and that is that what you hear here today is informational only and not actual medical advice. But the Cusp can provide personalized medical advice to members, and I'll talk about that towards the end of this Zoom.
Hi, everybody. Nice to see you from the Zoom room of the Cusp. So here we are. We're going to have a good time today with going through some real basic stuff that's fun to know and remember, specifically about how some of your hormones affect your brain, and then some things about how you'd make the transition perimenopause to the menopause years and the postmenopause years. And how that can also affect your brain. So we're going to get into a little bit of that so that you can have some just kind of basic information about that. And then we can tell you about some options on how to measure your hormones and what we can do to help you measure your hormones, and get on to the healthy part of your personal, getting to be your personal best. So at any rate, Taylor Sittler is here as CEO of the company, and I think he wants to say a few words and kick it off if he's going to get some stable internet here. It's hard to tell.
Yeah. Sorry about that. Looks like we had a little internet glitch.
Okay, Taylor. I set up what we're going to do so you can say hello to everybody and tell them what's going on.
Okay. Hello, everyone. Thank you for coming. Thank you for joining our webinar today. We're really excited to talk with you and learn more about you, actually. We're going to start with a short talk about hormones and the brain in this end of menstrual cycle and moving into perimenopause, because there's a lot going on. And before we start, I would like to introduce Dr. Louann Brizendine, who is a professor of neuropsychiatry at UCSF, former director of the UCSF Women's Mood and Hormone Clinic, author of The Female Brain, which was actually made into a movie, and also The Male Brain, which I enjoyed reading as well. So thank you for talking with us today. And what I'd like to do is start with a quick presentation.
Yeah, I think Taylor's freezing a little bit. So, Lauren, maybe what we should do is I can just talk a little bit about the hormones, and we can get into some of the aspects of our first slide. Now, everybody, you see these three hormones that are over on the right, where the conductor's pad is, and the big trumpet is, and the hormone AMH is. Those three hormones you're going to learn a little bit more about, and why you should care about them, why you should make good friends with them, and what they might tell you about your personal path into the menopause. So at any rate, so we're going to go back to the menstrual cycle for a minute. If we could have that slide. Taylor, is that okay if we go to that slide?
That sounds great.
Okay, great. So this may look familiar to you all from at some point in your biology class or something, but this is what it looks like all of our lives, women, after we've started our menstrual cycle. So if you look over there at day 1 there, where it says the 1 at the bottom there, and then it says menses. Day 1 is day 1 of bleeding. So day 1 of bleeding is how we count the menstrual cycle. And then, so you can see there in that first 2 weeks of the menstrual cycle, so that first big square where it says your verbal skills go way up as that purple line is your estrogen. As your estrogen peaks, your verbal skills go way up. And then as your estrogen peaks too, your sex drive goes way up. I always say, it's very funny, like if they're my graduate students, I say, well, you should definitely schedule to take your oral exams during that week, the 2 or 3 days before ovulation for your most verbal. But it's also how Mother Nature made it so that if you are interested in being pregnant, you can have sex on those days right before ovulation, because you see that big peak in the estrogen, it's what triggers your whole system to make ovulation happen and allow you to get pregnant. So then you can see that it drops way down there as you go into the second 2 weeks of your period. And remember, if ovulation has happened, look at that little dotted red line that goes there. The dotted red line is your progesterone, and there's none of it in the first 2 weeks of your cycle. But see, as it creeps up, 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 higher and higher, the progesterone is pumping out from that follicle that the egg just came out of and left that follicle behind. So it may make you more sleepy, a little bit more fatigued and tired, eating more carbs is very common. So you see as the big peak goes up with the sleep going up, and look the PMS part there. You see the arrow that's pointing to the last bit of that cycle where the progesterone is diving down there. That big drop in the progesterone and estrogen is the one that makes you, like, we used to call it in my clinic, the crying over dog food commercials sign, where you cry at anything, or even, and and lots of women say that, oh God, that's the time I'll scream at my kids, or I'll, anything my husband says, it feels like fingernails on the chalkboard. I just want to kill him. I'm very irritable at him. So I try not to snap too much at him. That last couple of days, about 85 or 90% of women have had at least some of their cycles have those kinds of brain effects that make them crabby. Of course, and then that clicks into the next couple of days as the cycle starts down there on day 29. This slide just decided to choose day 29 as when a lot of women have a 28, 29 day period, but you may have been someone who had a 27-day cycle all of your life, or you may be someone that had a 30 or 31 days. So it's very individual. And some women can actually say, I know within about 2 hours when I'm going to start my period, like clockwork, every month. So some women are very, very regular. And why that happens very regularly is that your system is so choreographed and so tightly and beautifully balanced that this trigger between your pituitary and your ovary is just like an internal clock that you have. Now that's what happens during all of your fertile years. And we're going to flip to the next slide and look what happens as we go out of that phase. Okay, just to orient you to what we're looking at right here. The top little boxes there along the top are what's going on in your ovaries. We just looked at that. So those fertile years that you have where your cycle is like clockwork, the estrogen going up and the progesterone going up in the second half. Then your brain, if you look at the brain down there, your LH, the luteinizing hormone, that has to do with ovulation of your egg, and the FSH, the follicle stimulating hormone, which has to do with making your ovary make estrogen. Those two from the pituitary are very clean, clear, very precise during your fertile years. And then look what happens as you tip over to the perimenopause. A lot of women that had a 31-day cycle all of a sudden have 29 days. Or if you had a 29-day cycle, you've got maybe 26, 27, something in that range. So the shortening of the cycle is one of the very first things women notice. Sometimes it happens around age 42. For other women, it doesn't happen till 52. So there's a big range in there of about 10 years. So that erratic estrogen in that middle column there from the ovary, the erratic estrogen that's going up and down. And then see what's happening also with the pituitary. It's also very erratic at the same time. That's because your eggs are kind of running out of follicles. There's not enough estrogen. And then the pituitary, that FSH down there, starts to make your screaming at the pituitary, make more estrogen, make more estrogen. The ovary is saying, thank you very much, I've retired, I'm done with the estrogen. So there's this miscommunication, misfiring, but often between the pituitary screaming higher and higher with FSH to make more estrogen, to the now deaf ovary, because it's not got any more follicles to make estrogen and respond. So that's why they measure your FSH often in fertility clinics, or even they used to measure it as you were going into perimenopause, but we found it's very erratic, and we'll show that in a minute in the next slide. And then I hate the end part of this slide because makes you look like you're flatlined after menopause, where your estrogen is low and your progesterone is low. FSH is, see how high it is, and your LH is all high like that from your pituitary. So obviously you're not flatlined after menopause. That's when the good time starts. But at any rate, so that just is to show how it goes way down, stays down, and your FSH goes up. Okay, in our next slide, I'm going to show you what really starts the rock and roll of perimenopause. So you see in the top slide there, the top is this is a six menstrual cycle. So there in the top part, you see it's a very regular bam, boom, boom, boom. If you're following the beats, you know, on music, it would be like 1 month, you know, 29 days, 29 days, 29 days, 29 days. So that would be very regular. Then if you look at the different part down below and the perimenopause, look at that miscommunication and erratic part of like your estrogen and your progesterone are kind of all over the place. Your FSH and LH are all over the place as well, because they're trying, that FSH keeps trying to make the ovary make estrogen, but the estrogen's not going to come out. But then all of a sudden, maybe it'll hit a follicle that squeezes out a lot of estrogen and it pops way back up again. So in the perimenopause, you may go through 6 months where you're kind of back to some kind of normal, but then you're not. So this is why we stopped measuring the FSH to say anything about perimenopause, because you might catch it on one day and not catch it on another day. So that's all over the map.
I have a quick question for you. So what happens, this was super informative, by the way. Thank you very much. What happens now? How are these changes in hormones linked to the symptoms and bleeding and things like that? Like, how does this actually impact a woman in perimenopause?
So one of the things that it impacts that a lot of women start to notice is, you know, in terms of the bleeding pattern, because if you have a lot of estrogen, estrogen is what makes the lining of the uterus get all puffed up and get lots of blood in it. And the progesterone is then every month when you ovulate, the progesterone comes and you clean out the whole system. So, you know, you have a certain amount of, you get used to the amount of blood you have on days 1 and 2 or 3 and 4. It kind of is similar from period to period up there premenopausally. But then you hit the perimenopause, and what happens is that the estrogen may keep pumping out, building up the lining, and you may not ovulate that month because the egg is just not responding. And then you don't have any progesterone, so you don't clean out that month entirely, but the blood keeps building up. So then maybe at some point in the middle of the next period or the next period, you have a blood flow that's all over the place. You know, a lot of women have like, they go through maxi pads every 2 hours, and that's a condition we call menorrhagia. And, you know, you can become even anemic there. So lots of women complain of really heavy bleeding during a certain phase of their perimenopause. And it can go along for, you know, a few years like that. I always, you know, I was going to say, Taylor, I often ask my audiences, I say to them, well, how long does perimenopause last? And so,
can we do that actually?
Yeah. Well, I said, how long does perimenopause last? A lot of women will say, too long. So, yeah, too long, that's for sure. But so what we know is it's between 2 and 9 or even 2 and 12 years. And so it's very hard to know when you start your early symptoms of the shortening of the period and maybe some heavier bleeding. It's a little bit hard to know whether you're going to be the 7, 8, 9 year or 12 year type person exactly, because up until recently, we haven't really had any hormones to be able to measure that. But the good news is Taylor will tell you some about that, is we do have something now, which is great to be able to help measure that. So that's the kind of what I call kind of like the orchestra of our hormones in our brain that goes on all of our lives. And then we get to this phase, it becomes like that bit of an erratic mess that you see in that bottom part of this slide.
Yeah, no, thanks very much. That makes a lot of sense. And so I think we have seen that physicians, you know, do try to test hormones. And you can see from this chart here why it's quite difficult for them to provide any meaningful information. Some will say, well, on average, FSH will go up during perimenopause and then into menopause. Yes, in menopause, it certainly is. But as you can see in this middle ground, FSH can be high, it can be low, as can estrogen and LH. And so a lot of the tests that doctors will traditionally do to determine your menopausal status really can't provide any useful information of where you are or how long you have to go. Lori, if you can go to the next slide, please. What we have seen in the last couple of years is, if you look at this green line here, this is a hormone that wasn't previously measured. It's one that is now used very frequently in IVF clinics to help determine fertility status. It really is a measure of the number of eggs that a woman is producing in any given cycle. And it provides a useful measure of also how much estrogen and progesterone the ovary is capable of producing. And you can see over time that will go down. And so we can use that to measure roughly how long a woman has between where she is now and when menopause will start. Now, the levels of this hormone that we have to check in order for us to be able to determine time to menopause are actually much, much lower than the levels that are used in IVF clinics. So if you were to go to your doctor and you were to ask for this test, most of the time, the test that you would get would not be able to detect these levels. This would just be undetectable. In 2018, the FDA approved a new test that actually is 100-fold more sensitive, and so allows us to get down to the levels now where we can see a woman's transition into menopause.
By the way, Taylor, that is just so cool. I mean, when I was running the Women's Mood and Hormone Clinic, we didn't have this, so we just basically had to guess. So each woman is unique, as you know, and so to have an individual snapshot would have been wonderful for my patients.
That's great. Well, and I think what I'd love to talk about is, with this new information, what do you think we can do? I mean, I think the question here is, there's so many women in perimenopause who are looking for answers. What can they do about it?
Absolutely. And if you knew, I mean, I think one of the nice things about knowing where you are is that, you know, if you're way, way towards the tail end, that might make you decide, and that let's say you're really miserable, you're bleeding really heavily, you're not sleeping well, you're crabby, depressed, and irritable all the time. That might make you say, like, I may have another couple of years of this, and this is just not consistent with how I want to live my life. So you may decide that you want to use some of the things that we have in our toolbox to help you through this. And it could be anything from, taking, continuous, birth control pills, hormone replacement therapy, the patch, or botanicals, or, there are many, many things that we have in our toolbox that we can offer to people, and actually let them test drive some of them to see what works best for you as an individual, because, we can't guess. We may be able to tell you about how long it is to menopause. And, if you found out it's 5 more years of this and you're already suffering like crazy, God, she did not put us on this planet to suffer. So, we got to do something to help you be your best.
That's great. And the last thing we wanted to talk about was, if we can bring the slides back up, as women then transition from perimenopause into menopause. So looking at the next slide, I think. There are a number of things that happen. So, there are symptoms that are associated with perimenopause that can stay. And additionally, there are these health risks that become more significant and can become pretty severe. Most people are aware of the risk of osteoporosis that happens when estrogen drops, but there's also a risk of Alzheimer's, cardiovascular disease, diabetes, and this is being particularly linked to hot flashes, as well as some increased risk for cancer. And so this transition is actually a really important point for women to think about, not only the therapy that they want to help them feel better, like you were talking about, whether it's hormone therapy or botanicals, whatever a woman's comfortable with, but also preparing, changing her lifestyle, maybe modifying her diet to really help avoid some of these risks that are become a big issue down the line. I mean, what do you see as far as, when a woman goes from perimenopause into menopause, what happens to those symptoms?
Well, the hot flashes can just continue to get worse because your estrogen is down so low. And once a woman starts getting triggered into hot flashes, I mean, I've had some women in the clinic that actually go on with hot flashes for 15 years, even after their periods have stopped. So
Wow.
some women get used to them and they're pretty mild, and you can take some things to just kind of help during the time. Those that are really, you know, that are really bothersome and keep you from sleeping are clearly something that you want to do something about. And the mood, irritability, and depression symptoms are something that we can also do something about. And those can kind of, for some women, those can kind of get sort of stuck. About 1 in 5 women sort of feels, you know, just that they don't have the usual mood bounce. I have women say, like, if I ask them, like, if your fairy godmother were here, what would you like her to do in terms of the way you're not feeling like you used to? And I've had a lot of women say, I just want my joy back.
Mm.
And, you know, if I have to live the rest of my life feeling this badly, you know, I just don't know what I'll do. If it weren't for, they'll say, if it weren't for my kids and husband, blah, 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 you know, so that's no way to live. And so those brain symptoms, mood symptoms, irritability, sleep problems, if you're not sleeping, of course, you're going to be irritable and crabby. So these things all kind of go together with each other. I think the long-term health risks are something to know about and to think about prevention and really talk about that for your personalized plan. You know, if you've got a history, if you've already got some osteoporosis that you know about, if your bones are already thinning, which a lot of women's are by the time they hit the menopause, then, you know, thinking about what advantage you can have by getting your estrogen replaced at some level. If you've got a large family history of diabetes, cardiovascular disease, Alzheimer's, you know, your specific individual history and family history and genetics really, really matter at this point to kind of think about what approach you want to take. So that's something that I always like to talk with women personally about, is a personalized plan just for you.
Great. Thank you very much. So we should, I think we've gone through kind of the basic presentation. We've talked a little bit about the link between hormones and symptoms, the link to AMH and how we can use that to determine the time to menopause, and then what the risks are and what the things are you can do about it, as well as how to plan for this transition. Thank you very much for talking, and sorry for the glitch earlier on. I'm glad I was able to come back and catch up with you. Let's move to maybe taking some questions from the audience.
Great. We have a couple so far, and a couple that were written in ahead of time as well. This first one is pretty interesting, and it talks about, is the test, this hormone test that Taylor was talking about, is this accurate if you've only got one ovary? Does that skew the results?
Interesting. So in that, yeah, I mean, I think there are all kinds of, maybe I can talk a little bit about the test conditions that were used to determine that time to menopause. As far as I know, they did not include women who had only a single ovary. So what we would do is, I would say that yes, we would have more of a difficult time predicting that. Given that situation, the AMH levels would likely be prematurely low, and we would incorporate the rest of the clinical picture to really help you, help guide you as far as your time to menopause. Now, if the AMH level were particularly low or particularly high, it could still provide a lot of useful information. So it really would depend on the individual test.
Got it. And that really skews more towards a write-in question that we got as well about being on birth control during perimenopause. Is it sort of, does that also, like, you know, this question came in saying they're still on birth control, but they're having wild fluctuations. Is the test going to be accurate if you're on birth control?
So the test that we do measures 3 different hormones, FSH, LH, and AMH. FSH and LH would expect to be affected by birth control. And so we wouldn't rely on those hormones. As you saw from the chart, though, they tend to swing very wildly anyway. AMH tends to be much less affected by birth control. And so we could still rely on that to help determine time to menopause. We would also look at menstrual history, BMI. There are a couple of other questions that really could help us in determining your time to menopause.
This is a really interesting question about botanicals and supplemental protocols. So some hot flashes definitely subsided after being on botanicals and supplements, but now they're starting up again, and there's been no changes in diets or supplements, and things are going all over the place. Any ideas about that with supplements, or are supplements better than hormone replacement, or is hormone replacement better than supplements? What's the right way to go for hot
I
flashes?
think it's a very personalized decision. I think some women really want to start with a natural approach. Others want to start with a more medical approach. Given all the data that we have so far, hormone therapy, particularly estrogen and progesterone together, tend to be, well, depending on the situation, but that tends to be the most effective and to deal with the largest range of symptoms. Now, some women really do find benefit from botanicals and certain supplements. I would say that benefit, the change that this woman is experiencing may be because the supplement is no longer benefiting her. It may also be because her hormones have changed. As Dr. Brizendine was discussing, the hormone levels fluctuate quite a bit. And so something that works at one phase of perimenopause may not work at another. And, the way that we deal with that in terms of hormones is we might change the level of hormones that we would give a woman. Maybe I'll pass it on to you. Is there anything you'd add to that, Louann?
I think that I like to give women a lot of options in their toolbox. And I do believe that one of the options, that test driving different approaches until we find the right one that matches you, whether it's botanicals or whether it's like the estrogen patch, the hormone patch, or a pill. We want to give you all the tools that we have in our toolbox that are known. And so test driving those for yourself personally is the best way to go with care providers that you really trust and that you can talk to and tell them, what's going on, and then that you trust that person to tweak it for you in a direction until you find something that suits you and fits well for you, because every woman is very individual in this transition. Even though the transition is somewhat similar, as we just talked about, you're unique. So I like to give the toolbox approach, and we can sort of start agreeing to select one at a time and test one thing at a time until we find the right thing for you.
That makes a lot of sense.
Makes a lot of sense. Yeah. Yeah. So another great question, and you started talking about this as well, Louann, but risk factors of bioidentical hormones. And Taylor, I know you're going to have a lot to say about this, but there was a previous large study suggesting high risk, but it seems some of the variables from that large scale research study was debunked or found to be misleading. Could you guys talk a little bit about bioidentical hormones and the risks or lack thereof?
Absolutely. Do you want to start?
Taylor, you can start. I think that if you wanted the only perfect hormone that's exactly like your body makes it is the one that comes right out of your ovary. And so anytime you're taking a pill or you're putting a patch or a cream on, etc., it's not totally natural. It's not totally bioidentical. It's not that your ovary would make. So just to keep that in mind, the way that your body produces it a little bit at a time, there's nothing that we have that can replace the identical thing that your ovary has been doing. So just keep that in mind as a basic principle, and Taylor can tell you some more about the bioidenticals.
Yeah, or maybe I'll start by addressing that study. I think the study that is being discussed here is the Women's Health Initiative, which came out about almost 20 years ago at this point. And that actually involved non-bioidentical hormones that were given mostly to an older cohort of women, some of whom had not had hormone therapy previously and were over 60. So they had gone multiple years past menopause without hormone therapy, and then suddenly were put on it. And I think, so what happened at that time was there was a risk between breast cancer and this treatment that was established. And I think the community has learned a lot from that trial. no longer do we think that there's a risk between estrogen itself and breast cancer. I think what we found is it's more about the pattern of delivery that makes sense. So starting these days, I think most places will use bioidentical hormones exclusively, meaning that these are compounds that are produced by your ovaries. To Louann's point, they can be produced in different quantities and at different times, but they're the same substances that are produced by your ovaries. And they're given usually earlier on. So we've shown that starting hormones earlier in the perimenopausal transition or early menopause transition tends to have better outcomes. It also tends to provide more relief from some of the symptoms in menopause. Using those bioidenticals instead of the non-bioidenticals, which were used in the study, seems to be better. And we now have more of an approach of trying to get to the minimum dose that provides the maximum relief. And I think between those things, we've started to see that hormone therapy is a lot safer. The other thing is that the risk of breast cancer that was originally attributed to estrogen is actually due to low levels of progesterone that are given in combination with the estrogen to protect the uterine lining. And so there are a new set of approaches that are now coming out to help reduce that risk further.
And I think one thing to keep in mind, Taylor, about that everybody that knows that study, that's why they stopped everybody's hormone replacement. That progesterone that they used that caused more breast cancer is a progesterone we do not use any longer. I mean, Europe stopped using it 45 years ago. In the United States, as soon as that study came out, it's called medroxyprogesterone. It's a progesterone not used anymore, and it was used, and in that study showed more breast cancer. The natural progesterones are not showing that. So just keep in mind that doesn't mean you can't take any progesterone. You can take the natural progesterones, the bioidentical ones that everybody uses now. So it's not the same as the progesterone.
Yeah, thanks.
Right. Yeah, thank you. There's another great question that sort of follows along this same path, but it's really now comparing like botanicals and hormones. And Louann, you talked about it a little bit earlier about like, every woman is different and, putting a lot of tools in your toolkit. But are there more advantages or side effects to put into consideration when you're thinking about botanicals versus hormones and when these options are best used?
I don't believe that you can predict. It's someday, maybe 10 years from now, when we can measure all of your genetics and the way in which each of you individually metabolize different products. We'll be able to select better out of our toolbox from the get-go. So, some women have side effects to a lot of the botanicals, or the botanicals don't work as effectively for them as some of the hormones do. And some women have more side effects to some of the hormones and may decide that they want to try some botanical combinations instead. So like I say, it's a test drive. It's really a test drive, and and like how you pick where you start. Well, how I ever pick with my patients about where I start is we discuss the options and what the risks and benefits of each are, but also, what side effects you've had in the past to other things. And we basically take our first best guess and start with that, and we'll see how you do, and we'll work with that for a while to see how it affects you. So I don't think there's any better or worse about the botanicals versus the prescription hormones. It's what's going to be most effective for you individually.
Yeah, and the only thing I would add to that is, regular check-ins and talking with your doctor more frequently can help you get to the right prescription more quickly. I think a lot of women end up going 3 to 6 months between visits, and that's really too long. After a couple of weeks, you can already start to either change prescriptions or, tweak the level.
That's a great point about not waiting too long when you're doing that. That's great. Taylor, for you, and I think this sort of ties into the new testing as well as risk factors, et cetera. It's a really great question, which is how long should hormones be used when you don't really know when you started perimenopause? So that's part one. Mm-hmm. And this question, they might have had been doing a lot of internet reading. They read 5 years is safest. How do you determine the approach with the best safety profile? So I think, two things here, like, it sounds like this person would really do well to understand when they're going to hit menopause and all of that. And then B, like, what is safe in terms of using hormones when you don't really know?
Yeah, so I think, the data is still mixed. We don't, and actually that 5-year window has recently been extended by the North American Menopause Society. So previously it was thought that they should only be done for 5 years and stopped, but more recently we're seeing that women can actually take hormones for a longer period of time and still have those benefits without the significant downsides. So, I think we are still learning. Now, the part of the purpose of offering this test and looking at AMH levels is actually to help women decide when the right time to start hormone therapy is, because there isn't really a good one. And if you don't know how long you're going to be in perimenopause, there's not a good way to understand where that starting point is. A lot of physicians will actually wait until women go through menopause, which is a year after their final menstrual period, and then only start hormones after that. And I think, given the data that we have, that's actually a little bit late. That's actually waiting for women to go through estrogen deprivation is kind of a way to think about it, for a long period of time before starting these. I think we believe that starting them in perimenopause before you experience that long deprivation is really a better way to go. And while we don't know exactly where in perimenopause to do it, having an understanding of when you'll reach menopause can help you pick the starting point.
And I think once you've already reached menopause, to this person's question, which is a really important question, because a lot of doctors, and remember, I want to say that you guys listening as consumers and patients should know that only 20%, so 80% of OBGYN residencies do not require an education or any course in perimenopause or menopause or hormone replacement therapy. Since so it's unfortunate, but a lot of doctors out there are pretty out of date, even a lot of OBGYNs, and this issue of the 5 years only, you'll hear that from a lot of your doctors still, but the more up to date that the North American Menopause Society and others have basically said there is no endpoint. If you're taking estrogen to help your bones or replace the deficit, like Taylor said, of estrogen, and it's a whole nother ball game. And they've even come out recently saying that there was some kind of a hard cutoff that you're supposed to stop women's estrogen when they're 65, and that has even gone by the wayside as of 2019 by NAMS as well. It depends on the individual woman's situation, what her risks are for different diseases, how well she's doing on what she has. So at any rate, I just want to put in there a pitch for the fact that you really need to go to see a menopause specialist, somebody who's been trained in menopause, because most doctors, surprisingly, even OBGYNs that are that have been out of training for more than 20 years, that there's not a course for about 80% of them. So just saying.
Shocking, isn't it?
It shocks me too to read this. I feel badly because I started the Women's Mood and Hormone Clinic 20 years ago, and I assumed that by now they would be all over the country and it would be a standard thing that women were taken seriously in perimenopause and menopause, and that their questions and their all of their symptoms would be addressed appropriately, and then we'd make these toolboxes like just available to them about how to live their best lives at this transition time of this, say 2 to 9 or 2 to 12 years. This is not, it's just not reasonable or fair in my mind, and the medical profession has been amiss in not having more menopause specialists available. And I think that's why you see a lot of these companies like the Cusp coming into being, because it's really hard to find someone to help you that is a specialist in menopause. So
interesting. This is a great question that really goes back to some of the charts that you guys were showing earlier, but especially as it relates to irregular periods and false positive pregnancy tests. Could those positive false positive pregnancy test be a result of perimenopausal hormones or the changing hormones that you guys were talking about, you know, that happen when they're going through perimenopause?
Taylor, is that HCG they're talking about?
Yeah, I believe so. So, I mean, without knowing the specific test, it's hard to answer. But typically, hormone tests look at a different, typically pregnancy tests look at a different hormone, not one of the hormones that we showed. It's human chorionic gonadotropin, which is really only produced by a growing fetus. And so a pregnancy test, if it's a traditional pregnancy test, would not be expected to be affected by perimenopause, as far as I know.
You might think you're pregnant because you've skipped a few periods, and you may be
Yeah.
getting bloated. You may be getting bloated, and you may
Right.
feel like, God, this is how I felt when I was, you know, a month or 2 or 3 pregnant before. So it may be, you may be a feeling of being pregnant. Yeah.
Yeah. Yeah, it looks like with this person that they got 2 positive pregnancy tests and then got their period 2 weeks later than usual. So it's, yeah.
Wow.
Yeah, it's
Well, they
interesting.
probably had what we call a spontaneous miscarriage then,
That's what I
because
was,
that hormone, the HCG would have meant that there was, you know, a little tiny fertilized
Yeah.
egg in there somewhere to make that particular hormone, but it would have meant that you had a spontaneous miscarriage.
Got it. Got it. Okay, great. This is a fantastic question. Are there any differences in hormone treatments for women of color?
Oh, no. I would say that that's a, I would say that access to care and access to good menopause care probably has some differences in terms of, you know, different of women of color, and just, you know, as you know, has become very clear recently, you know, in the whole COVID epidemic, you know, is that, but there's nothing different in terms of the approach to menopause or the necessarily symptoms of menopause. There's one little difference that I would think about, though, that occurs to me, which is that because if African American women, so we know that African American women start their menstrual periods at puberty about a year before, at the average age of 11, whereas Caucasian and Hispanic girls started about age 12, and Asian girls started about a year later at about 13. That's their average age. And one of the reasons for that, and that's been shown for over, you know, 30, 40 years that that's been true. And then if you have more body fat, you start your periods earlier, but you also often, because estrogen, your body fat makes a little bit of a type of estrogen and can kind of like delay menopause a little bit in some women. So if you have more body fat, you may go into menopause slightly later. So I would say if there's anything different about African American women, Asian women, Caucasian and Hispanic women that you can look at from like the start dates and puberty of your period and the finish dates, that would be it. But a lot more of it tends to have to do with women who are smokers, tend to go into menopause earlier, and often have more osteoporosis and that kind of thing too. So other things really affect going into menopause more than what your racial genetics are.
yeah, and I think the treatments are all appropriate for all ethnicities. I'm not aware of any that are more or less appropriate based on your race.
Great. Okay. Another good question about diet and menopause and sleep. So as this question says, assuming diet is impacting your symptoms as you're heading into menopause, this is the assumption that they want you to go by with this question. Their sleep is not as good, but their diet is optimal. So they're interested in trying natural techniques and would appreciate any guidance here. So really, this is a question about diet and menopause and more sort of lifestyle and looking at more natural techniques.
Got it. So if I understand the question correctly, it's what things can you do outside of prescription medications as you move into that menopausal transition? Is that a reasonable reframe?
Yes, that's a very reasonable reframe around natural techniques to help with sleep. making the assumption diet is optimal. Yeah.
Got it. So there are, if we leave diet aside, because there actually are a number of dietary changes that can be really helpful in this transition. There's certainly, so if you look at sleep specifically, I think there are issues around sleep hygiene that can be really helpful. There are supplements that, and we have a number of specific ones that we'll offer depending on the individual woman. And then, I think there's some relatively good evidence that better exercise can actually really help improve a woman's sleep as well as potentially her mood. But I'm going to kick it over to you, Louann, because I think you probably know a lot more about this than I do.
Well, the sleep issue is like a wonderful question, great question, because, if mama ain't happy, nobody's happy. If you're not sleeping, you're not going to be, living your best life here. And if you've got an optimal diet, that's wonderful. And you probably know a lot about the sleep hygiene, and, our bodies get very used to a circadian rhythm, so that getting bright light in the mornings and getting some cardio exercise, before about 4 o'clock in the afternoon, possibly, taking a nice warm shower or something, and things that, things to eat for dinner that have tryptophan in them, like things like, chicken breast. I mean, things that are having things in it that help you go to sleep. The B vitamins also help you go to sleep. So if you're taking multivitamins or something, it's better to maybe take them at dinner time. I mean, those little things can actually be helpful. But if the sleep is related to your feeling too hot and hot flashes, and you're throwing the covers off and you're thrashing all night, then that has to do with your estrogen deficit that's causing the hot flashes. Because what estrogen does, is like if you're in a room with other people and the temperature changes in your life before menopause, if it changed by 10 degrees, went up by 10 degrees, you might feel hot. Everybody might be hot. You're open. But if you're a menopausal woman and you're in the room and the room temperature changes by 1 degree, nobody else is feeling hot, but you're feeling hot. So that's what estrogen does. It really narrows the level at which your body's going to feel hot from other people, from what used to be normal for you. So it's really important to sort out what it is that's causing your sleep to be bad. And if it's this issue of estrogen deficit, then that's one approach. If it's because and that would be the thing that was specifically related to perimenopause and menopause that I can think of. I don't know, Taylor, can you think of some other things?
Yeah, I mean, I think what we talked about was, there were sleep hygiene issues that we discussed. There were, particular vitamins, tryptophan for dinner. And then there are some supplements that you can take like maca and some other things that can really help with sleep. I think that's pretty much it.
And some women, when they replace their estrogen and those they're not always hot flashes, but hot flushes or that temperature change at night goes away, they sleep better too. So that can be something to consider.
So there was a question that came in ahead of time before the event specifically around the test. Taylor, if you could talk a little bit more about the hormone test and what the Cusp is offering around that, and why women should be thinking about taking this test. Specifically, when should women consider taking this hormone test that you guys are offering now?
Mm-hmm. So the test was really designed for women who are in perimenopause, in that transition, and wanting to know more information about menopause, wanting to plan, wanting to understand what's happening with their hormones. The specific ages for which the test was approved by the FDA is 42 to 58. So those are that's roughly the age range that we would expect. At 58, most women have reached menopause, and so it's no longer helpful to predict the time to menopause. But for some women, I think even before the age of 42, once a woman starts to feel any of the symptoms that are associated with it, hot flashes being the sort of canonical, but can be related to unexpected mood swings, sleep deficit, joint pains. There are a number of different ways that menopause can make itself known. Oprah famously in her article last year talked about palpitations. That's how she found out that she was in perimenopause. So there are a number of different ways that women come to that realization. But I think as soon as you have this inkling that you might be in perimenopause, it would be useful to take the test to figure out how far you have to go and when you want to think about doing something.
Great, thank you.
Oh, actually, sorry. The one other thing that I wanted to say about what we're offering is we don't just rely on the actual level of the hormone. That is helpful, but what's really important is to take into account the rest of the clinical picture and put all those pieces together so that you can better figure out what to do next. So really, the two important parts are the hormone levels and then having that clinical visit to bring it all together.
Got it. Great. Another great question, which is, are there options for breast cancer survivors who cannot take hormones?
Yes, absolutely. And Mindy Goldman, who is one of our advisors and has been working with us for a while, is actually an expert in this. She's a professor at UCSF and works with cancer survivors all the time. There are some very commonly prescribed antidepressants and other medications that work really well to either reduce hot flashes or some of the other symptoms associated and can be great for women. And again, Louann, you know a lot more about this.
No, I just want the women out there that either had breast cancer themselves or have a family history of breast cancer, just to know that we have a very deep bench of people who can help you with that, help you with what tools will be in your toolbox and what you should and shouldn't take, and help you find the right combination for you. So that's an amazing expertise that we have with Dr. Mindy Goldman, who's been treating this and specialized in this for the last 30 years. So you couldn't do better than to have access to Dr. Goldman.
That's great. Yeah, because there was another question about someone whose mom died of triple negative breast cancer, and this person does not have the BRCA1 genome, but would still be worried because she wants to try hormones. So it's great. I'm sure she's relieved to hear that that's an option as well. That's
yeah, she can take them, but I would suggest that she takes them, under supervision of our breast cancer specialists on our team, and also basically lets her doctor know that that's what she's going to do.
Yeah, totally.
Yeah. And also, I think it's important to do the other common preventive screenings that are recommended, right? So for a woman, either over 40 or over 50, depending on her situation, getting mammograms on a regular basis, and just making sure to do the things that are recommended can really help.
Good. Well, good. I think, that looks like that's the last of the questions that we have here. And we've got about 5 minutes left. Any final words from Taylor or Louann?
I guess, the one thing that I will say that has really struck me as I've been learning more about this is just how much has been studied and how much we do know about these changing hormones and how they impact women in this phase of life. And I've been just surprised as a doctor about how little of it has been brought out into practice. I wonder, could you tell us?
They didn't teach you that much about it in medical school,
no.
did they, Taylor? I know.
No, they didn't. I've really been kind of learning on the job, so to speak. And I wonder about your perspective on that, because you've really been in this for a long time.
Yeah, I've been doing it for a long time. But so what I'd like to say to the audience out there is I really want you all to feel that you both, that what you're going through is normal, that, and that it's a very individual, unique, and of course, it's not talked about very much amongst women often because it's sort of confusing. But I just want you to feel like it's very normal. We've been doing this for a long time, this group of us here, and that you deserve to feel better, and we want you to help you with your personalized toolbox, just because I would like you all to feel better and be able to feel like the hopefulness that comes from knowing that there's something that's going to work for you, and that we're not going to quit until we help you find that thing. So just, I want you to take some assurance and hopefulness from that.
Yeah, thanks.
That is lovely. Thank you so much, Taylor and Louann. Really, really great. I want to thank Taylor and Louann very, very much. I love, Louann, how you ended it on feel better, because at
Thank
the
you.
Cusp, we're really committed to helping women going through perimenopause and menopause feel better. And part of helping you feel better is understanding where you are in the journey, which is why we're really excited to offer the latest in science with this new at-home home run test, which you can go to thecusp.com/hormone-test to find out more information about it. Or if you're interested in finding out more about our expert care service, you can go to thecusp.com and sign up and be under the care of like wonderful doctors like Dr. Mindy Goldman or Dr. Erin Conlon, or any of our other fabulous practitioners that can help you get through this journey. Just to let you know, Louann is on our medical advisory board, and she helps us set up those protocols for care. And we're really very honored to have her be a part of our company and a part of our advisory board, which is great. But really, we're here to make you feel better, and we're here to help you understand where you are in your journey. So please visit us at the Cusp, and we look forward to caring for you. So please be well, and thank you for attending.
Thank you.